Deputy Secretary at Cornerstone All India Students Organization, take this fortunate opportunity to welcome you all for our today's webinar on ICU Examination and Management on occasion of World Health Day, which is celebrated on 29 September every year. I welcome our today's speaker, Dr. Varalakshami ma'am, on behalf of this organization. I would take a few minutes to present ma'am's achievements over the years. Ma'am has worked as an assistant professor at Kugler College of Physiotherapy, Guntur, Sanjeevani College of Physiotherapy, Sangareddy Hospital, and at Apollo College of Physiotherapy, Hyderabad. She is presently the HOD of the Department of CTVS Physiotherapy and also the Vice Principal at Apollo College of Physiotherapy, Hyderabad. Ma'am has a great clinical experience in critical care and ICU cases of cardiovascular and respiratory disorders, burns, and many more. She has worked as a chief physiotherapist at Lalita Gayatri Hospital and worked under Dr. Ramesh Mani, who is a chief anesthetist and a director of Lalita Gayatri Hospitals. Amongst her so many achievements, she has also received Young Significant Achievement Award from Physio Foundation of India and is one of the editorial board members for the International Journal of Physiotherapy. It is a pleasure to have you with us, ma'am, and we once again welcome you. Over to you, ma'am. You may commence with the webinar.
Thank you, Nafisa, for your nice introduction.
Thank you, ma'am.
Today, my topic for this webinar is the ICU examination and the management. I think most of the people joined here are the students, clinicians, and the working physiotherapists and academicians also. And they might also work in the ICU setup also. Now I'll go in detail about how we are going to assess the patient when he joined in ICU and what is the management from our side. Coming to the ICU assessment, each and every system you have to assess by whenever the ICU patient joins in an intensive care unit. Whatever may be the condition of the patient, you have to assess each and every system. Why? Because there are other comorbidities which may lead to the condition of the patient very critical. So coming to the assessment, there are so many systems in our body like neurological, cardiovascular, respiratory, renal and hematological and gastrointestinal systems. See, all these systems, if you thoroughly assess, you may come to a provisional diagnosis. So and so the patient is suffering from these diseases or something, so that you can have a proper plan of your own treatment protocol. Coming to the neurological system, the main neurological system assessment terms of ICP, that is intracranial pressure. So normally the intracranial pressure is 5 to 15 mm of Hg. When this increases, then the patient may go for unconsciousness or any another neurological complications like paralysis. So that's why whenever the patient unconsciousness, the physician will go and see the pupillary reflex. When he sees the pupillary reflex, by putting the torchlight, when he sees the constriction of the pupil, then he will say the prognosis is good. If he is not going to see any pupillary reflex, then the physician will say the prognosis is very bad. So by seeing that proper neurological assessment, whether you are see in the ICU, it is not possible for everyone to check all the process of the assessment in a pattern. Like you are going to for a sensory assessment, cranial assessment, motor assessment, and then reflexes, tendon reflexes. We can't do. So minimal assessment, which will make you the patient is whether stable or not. So the main one thing is you are going to see the intracranial pressure. And coming to the cardiovascular system, so this is the most important system where we are going to have our treatment protocol. So first of all, you see whether the vital signs are normal within the range or not. Then you go for arterial blood pressure. Then you go for central venous pressure. Why? Because whenever the patient comes with any emergency, they will admit in the intensive care unit. So in that, they will immediately place the IV line. Or if the patient is having any heart disease, they will connect the central venous line. That is jugular venous pressure. You will see the jugular venous pressure. Why? Because it will mainly assess the right ventricular pressure. So the normal CVP is 2 to 6 mm of Hg, which will indirectly assess the right ventricular function. And coming to the pulmonary artery pressure and pulmonary artery wedge pressure. So these are the most important pressures which will assess the left ventricular. So when the patient is having high BP and the any heart failure like left heart failure or right heart failure, or any pulmonary hypertension. So you want to see these pressures whether they are within the normal or abnormal. So everyone will be seeing this monitor in ICU. So you have to see the graphs like the normally the BP, then oxygen, then that's SpO2, saturation of oxygen. See, mainly in this COVID condition, a pandemic, everybody is very scared. Why? Because nowadays the patient doesn't have, the patient will see it very fine. The individual, even though he is affected with COVID, he will be very fine. But his oxygen saturation suddenly falls. That is nothing but silent hypoxia. That is why when the patient is admitted in ICU, you have to continuously monitor his by means of pulse oximeter, his saturation of oxygen. So which will enable the stable condition of the patient or not. And this is the how you will see the CVP, that is assessment of the jugular venous pressure. We will see the highest point of pulsation in the internal jugular vein. And coming to the respiratory system, so in the respiratory system, first we will see like observation and palpation and examination. So in this process we will observe how the patient is. Mainly whenever we are going to assess the respiratory system, we will see how the pattern of breathing, how the patient is breathing, whether he is increasing his work of breathing, or he is using his accessory muscles, or he is using the main muscle, that is diaphragm. Like that you have to see the patient's pattern of breathing. Then you have to observe the fingers and the toes, and whether the patient is having clubbing or cyanosis. And then you have to see the nasal flarings. This is the main important diagnostic one, which will, even though the patient says, are you well, are you breathing normally, if he says okay, I'm normal also, then you have to see the flarings of the nostrils, which will enable you that the patient work of breathing is more. He is urging for the breath, he is having difficulty in the breathing. So in that way, by seeing the flaring of the nostrils, you can assess the patient that he is having some problem with the respiratory system, or whether he's the problem may be because of increased oxygen decreased oxygen concentration, or increased carbon dioxide concentration. So like that you will see an observation from head to toe. You have to see, because in ICU you have to finish very fast, you can't take most of the time to assess only the patient, so that it will delay your treatment protocol. So important things you have to assess. Then coming to the palpation, in palpation you have to see whether the patient is having edema. Edema means whether there is any comorbidities, or because of the cardiac conditions, or because of the liver conditions. Like that you have to see, or if the patient is having subcutaneous emphysema. So then after going for that, you'll see percussion. Percussion is nothing but to assess the lung density. How the lung will be, whether the patient is having collection of air in the lung or collection of the fluid in the lung. But to know whether the density of the lung is dull or resonance. By means of that, you can have a provisional diagnosis. For example, the percussion is a dull sound, that is a normal. That is abnormal. That is, the patient is having collection of secretions in some part of the lung. Whether if you are tapping on the upper lobe, like apical lobe, then you know that the patient is having apical secretions. Or if the patient is having resonance in the lower lobe, so you can say hyperresonance or hyporesonance. So if the patient is having hyperresonance, you can also have that idea that the patient is having pneumothorax in a particular lobe, where are you are going to percuss. So at the like that you can assess. Then coming to the expansions, so you are the patient is already agitated and he's admitted with the in the ICU, and he's having all the central venous lines, everything. You can't take the inch tape to assess the expansions. So by seeing the fall and raise of the chest only, you have to assess whether the expansion is within the normal range or not. So normal, the inspiration expression ratio is 1:2. So by means of that, you have to see how much time he is taking for the inspiration, how much time he is taking for the expiration. So by seeing the fall and rise of the chest only, you can assess how the patient is having the breathing problem, whether it is having the normal or abnormal. Then after that, when the patient has undergone any investigations, you go for the seeing the chest x-ray to confirm your provisional diagnosis, and whether he is on ventilation, any like external support of oxygen. You see what is the mode, whether he is supporting, or with the mission exclusively only the mission is supporting the oxygen therapy for him. Then if the patient is using any humidifiers, so that you can know which drug he is using for the humidification and how much of oxygen is sending to the patient through the ventilator, and what are the airway pressures, because most probably in the ICU they'll give the positive pressure ventilators only, so that to prevent the collapse of the
जब आप
alveoli.
गुजराती में बोला
Sorry,
Ventilator only.
sorry. Hello, I'm audible.
Yes,
Shweta, I'm
ma'am, you're
audible.
audible.
You are
Yes,
audible.
ma'am.
Okay, okay. And after that, you are going to see the airway arterial blood gas analysis. This is the most important investigation to see in the ICU whether the patient may be going for acidosis or going for alkalosis. And this acidosis and alkalosis may be because of respiratory or because of metabolic. Why? Because without unnoticing the ABG, like oxygen concentration, carbon dioxide concentration, and then base excess, then H plus ions, then sodium, potassium. See, all these are very, very important. Why? Because somebody will, for example, if the potassium is less, that's why they'll keep IV line for the ICU patients. If the potassium is less, the patient may go for partial paralysis. You may think that some neurological problem is there, that's why he is having nervousness. That's not the criteria. You have to see all the investigations, whatever he has undergone once admitted in the ICU, so that you can have your own diagnosis and to plan your own treatment. After that, then you can go for assess the sputum, whether he is having cough, like dry cough or protective cough. And this is the most important renal like system which is going to ignore usually, because one thing, the fluid balance is very, very important in the for the ICU patients. Why? Because if the patient is mobile, like the patient is able to go walking within the ICU, then there is no problem for the fluid balance. If he is bedridden, then how much they are giving, how much that is input and output is very, very important. That is why to prevent the formation of edema. And serum electrolytes, I already told you, sodium, potassium, and magnesium and calcium are very, very important to see what is the normal value and whether he is going for abnormal or normal. And coming to the gastrointestinal, see, because of lot of drugs they are giving to have the stable condition of the patient, he may develop gastritis or enteritis or some, I mean, abnormal things in the intestinal system. So whatever may be the root, and also if he is unconsciousness, they may give through the Riles tube. Whatever may be giving the food, they'll give in the liquid form only. So what is the nutritional support he is taking and how much he is taking, so that everything is important. And coming to the general assessment, I already discussed that how the position of the patient is, how the patient is positioned in the ICU. Like for example, he's conscious, then how he is going to sit or how he is going to lean. Like, because why I'm saying is, if the patient is having any urge for breath, so he will adopt usually the Fowler's position, that semi-Fowler's position, that is half-lying position. So the bed when head up position, so that what will happen in the semi-Fowler's position or the half-lying position, all the accessory muscles will go for the shortened positions, because he is already urge for breath. He is not using the diaphragm, that is normal main inspiratory muscle. So he will rely on the accessory muscles. What are the accessory muscles? Like sternocleidomastoids, scalene, pectorals. So he will use more of the accessory muscles to take the inspiration. So in order to reduce his work of breath, he will go for the slouch position. In the ICU, if you observe, the patient will be leaning backward, or he will adopt, without his knowledge, he will adopt so many relaxation positions while sitting on the bed or sitting in the chair. So that's why, to confirm your diagnosis, you have to see how the patient is sitting. And even speaking also, if the patient is having a problem of dyspnea, he'll have staggered breath, staggered speech. So he will give gap in between the words. And how the ventilator is provided, whether he's through the nasal cannula or through the endotracheal tube, or he has undergone the tracheostomy procedure. So everything you have to see. And what is the ventilatory mode? I already told you, it is intermittent mandatory ventilator or synchronized intermittent mandatory ventilator or control mode. That is controlled mandatory ventilator, that is CMV. First, initially, when the patient is unconsciousness, they'll use CMV. Controlled, everything is controlled by the ventilator, positive pressure ventilator. When the patient has like little consciousness and he has the control over breath, then slowly they will switch on to the synchronized intermittent mandatory ventilator, that is SIMV mode, so that the patient will synchronize with the ventilator provision of the oxygen, that is inspiration expiration will be along with the ventilator. And one important parameter you are going to see in the ventilator is fraction of inspired oxygen, like how much of oxygen to give initially to the patient. Why? Because to prevent the oxygen toxicity. That's most probably it will be 21% at the initial stages. Then obviously you have to see the vital signs, that is temperature, how much he is having, the BP, respiratory rate, heart rate, and Glasgow coma scale, whether if he is unconsciousness, then intracranial pressure. And what are the external tubes he is having. Why? Because to position the patient you have to see and these tubes to be not to be disconnected or not to be kinked. That's why it's very, for example, if the chest you don't know how to position and you're kinking the chest tube, we will keep for drainage of the intercostal drainage. We'll keep the intercostal drainage, that is to remove the secretions collected in the lung in a particular lobe. If you kink the tube without your knowledge, then the in abdominal pressure or transpulmonary pressure will increase automatically, and then the secretions will not come out of the lung and or drain to the bag which is attached to the patient, and he may go for faintness or dyspnea more. So all these you have to, and one important thing is drugs. Because of the drugs also side effects may come. For example, if he is on more of steroid, so all the systems will work very less. That normal function will lead to reduces. So that is why you are going to see whether he is on ACE inhibitors or any steroids, or he is using any like bronchodilators. So everything you have to see. See, coming to examination part. So I already told you, like cyanosis, whether it is central cyanosis or peripheral cyanosis, and clubbing also, the how much he's having, like grades of clubbing, whether he's having any levo bond angle. To know the clubbing, how much levo bond angle is there between the two nails. So to know that, you have to see each and everything. And who are all the patients who are admitted into the ICU? So most probably preoperative high risk surgical patients, and postoperative patients who is unable to mobilize the secretions, and neurological patient who is unable to cough effectively, and patient receiving mechanical ventilation who has a tendency to retain secretions, and patients with pulmonary disease who needs to improve bronchial hygiene. And these are all the prophylactic indications whoever admitted in the ICU. What are the therapeutic means? So these are atelectasis due to secretions or retained secretions, or the patient is having abnormal breathing pattern due to primary or secondary pulmonary dysfunction. Primary or secondary means primary pulmonary dysfunction exclusively the respiratory system. Because of the respiratory dysfunction, the patient is having the respiratory symptoms. And secondary pulmonary dysfunction means, for example, he is having liver disease, or he has undergone surgery. So because of that surgery, he is having some respiratory complications. So like that, you have to see whether the breathing pattern is due to exclusively the dysfunction of the respiratory system or to the comorbidities. And then whether he's having obstructive lung disorders, and which results in decreased exercise tolerance. Then musculoskeletal deformity that makes breathing pattern and cough ineffective. These musculoskeletal deformities are nothing like but scoliosis, kyphosis, or any chest trauma, or any rib fractures like flial chest, and all these. And the patient is having chronic obstructive pulmonary disease, the chest will become pectus excavatum, like pigeon chest. So all this you have to see, so that you can plan your proper treatment. And what are the goals to give into the to the ICU patient? Like, you have to, main goal is to prevent the accumulation of secretions. Why? Because most of the ICU patients, they will fear, if I start walking, what will happen to my all the external appliances, like external tubes, or I will get giddiness, I may fall, like that they will have fear. So most of the patients will not be willing to get up and start also. So your goal is mainly to improve mobilization and the drainage of secretions, and to promote relaxation by means of improving their breathing patterns. And by if you increase the breathing pattern length, then automatically the respiratory function will increase. And once all this increases, finally you are going to improve his cardiopulmonary exercise tolerance. And you have to take certain precautions while teaching all these, while improving your goals. So mainly untreated tension pneumothorax. If you don't know, by mean like the patient is having the tension pneumothorax, if you touch the patient, like if you ask and go to do the breathing exercises, then immediately the patient may collapse. Why? Because already there is so much of air inside the lung, and it created the increased the pressure of the intrapulmonary pressures automatically. So the patient is having already high BP, like pulmonary hypertension. So if you go and ask the patient, so you sit up and do the breathing exercise, immediately the patient may collapse. So when I was doing my MPPG, when I was doing my PG, I don't know, because I at that time I'm studying. I'm saying my mean like practical example. I have seen the patient. He is having mitral stenosis. I don't know, and I went, and as usual, we are in the postings. Usually, we'll do the mistakes only. So I went along with my friend, and I went and I taught the breathing exercises. After 20 minutes, immediately he collapsed. Why? Because he's in already left ventricular failure. I don't know, because all the pulmonary artery pressure is increased and wedge pressure is also increased. So that is why you should be very cautious to know the all the contraindications. And then abnormal coagulation profile, whether the patient is suffering with the status epilepticus or status asthmaticus, or immediately following intracranial surgery or head injury like a brain injury or trauma, and osteoporotic bones. Why? Because most of the cardiac surgeries will be done in the elderly patients only. So you have to be very careful by treating the elder patients. And recent any MI or unstable vitals, or immediately after tube feedings, and you have to be very careful with sutures and intercostal drainages. And coming to the treatment, what is your hierarchy of treatment? See, everybody has a myth, like if you do the cardio branch is very easy to finish the course. Most of them will think that only ortho, neuro and sports, like I mean, what I experienced I'm saying. So most of them will have that ortho cardio, ortho neuro and sports is the best branch, and if I don't get the seat, then I will opt for cardio. It's not like that. See, you will get like more satisfaction and uh, appreciation from the patient if you have give proper treatment to the proper individual like condition of the particular condition of the patient suffering. So what is your hierarchy? Everybody will say, hardly cardio means breathing exercise only, no? So if you do breathing exercise and ankle toe movement, that is okay. It's not like that. So in the ICU also, particularly you have to follow the hierarchy of treatment. Then only that you can see the improvement and you can reach your goals. See, what is the hierarchy means? First, you have to position the patient. Once the patient is comfortable in his position without any discomfort, then you can achieve half of your treatment goal. Why? Because of the position only the patient is getting all the abnormalities. For example, if you like continuously for 1 or 2 hours, how you will feel? You will feel body aches only. See, most of the people in this COVID pandemic, they don't want to stay at home only because of this lockdown. So many people increased in their weight without any physical activity, and all the patient, all the individuals also might be having some comorbidities, like sitting and eating, not going out. So they may get more comorbidities like diabetes. And because of the emotional tension at the home, like because of children are staying at home only, they will not listen and the stress will increase. All this leads to comorbidities, hypertension, diabetes. So you know how to deal with that. That is, hierarchy is very important. Which one should be given first, which one would be followed the next to have the your to reach your goal. So first the body portion, then go for mobilization and your protocol of exercise, whatever the type of exercise, then breathing control maneuvers, then coughing maneuvers, then range of motion exercises, then bronchial hygiene techniques, then manual techniques. Like if these are not working, then you go for manual techniques, and finally suctioning to remove the accumulated secretions. See, all these exercises should be followed through these principles only, like frequency, intensity, type of exercise, and time or duration of exercise. See, frequency means how many times you want to give. For example, you want to position the patient. So you want to turn the patient. You're not able to see it. So you want to turn the patient. See how many times you have to turn the patient in the ICU. You should know. You can't say that, sir, you can turn once or you can turn twice. It's not like that. You have to be emphasizing to the patient why these many times, why this much you have to do, so that you have to explain that so many people are not getting improvement because there is a communication gap between the patient and the therapist. They will not have a proper communication, proper explanation of whatever you are going to give the treatment. If you have that capability, then automatically the patient will listen whatever you are teaching for him, for his benefit. So that is why the frequency is very important, and intensity. See how much you are going to start with the particular individual, because it will differ from each individual to individual. See, whatever may be the in the books, you can't follow the same thing and apply for the every patient. It depends upon the need of the patient. For example, if the patient is more interested, he'll do more times. If the patient is not interested, then he will not have an interest to do at all. So depends upon that only you have to fix the intensity. Most of them, they will think in the book, they will see it depends upon the maximal heart rate. It's not like that. And then type of exercise, whether you are giving aerobic exercise or resisted exercises or both combinedly, or any Pilates or anything, any type of exercises, you have to fix what type of exercise suits for the patient. See, Pilates exercise you can't give for the elderly patients. You can't ask the elderly person to go and do the Pilates exercise, because Pilates has more effect on the cardiovascular system. So it depends upon the need of the individual. You have to emphasize which type of exercise is useful for the patient. And then finally, what is the duration of your each session and duration of your total session. See, each session means, for example, you are going to give 3 sessions per day. So morning, afternoon, and evening. So morning, how much you are going to give, either 20 minutes or 15 minutes, or afternoon, how many time, how many minutes, and totally whether you are going to give 45 minutes or 60 minutes. So you have to do these, particularly follow these principles of exercise, whatever may be the type of exercise you are going to give for the patient. And coming to the first one, positioning. Why the positioning is important and you will get half of the benefit of your treatment goal means, it optimizes the oxygen transport by improving ventilation perfusion mismatch. Usually, ventilation perfusion mismatch is the one culprit which will increases the patient's carbon dioxide levels. That is why when you position the patient in a proper thing, then automatically the ventilation perfusion ratio will reach near normal. That's usually it is 0.8. So 0.8 to 1 is the ventilation perfusion ratio. Then once this mismatch will reduces, automatically it increases the lung volumes. Once the lung volumes increases, the capacity of the lung, the compliance of the lung will increase automatically. So if the compliance increases, the work of the breathing done by the patient will reduces. Why? Because automatically the lung will go for elastic recalling of the lung, that is in the expiration. So the patient doesn't have any effort for the inspiration, so that his work of breathing will reduces. Once this all reduces, then the workload on the heart also reduces. So the left ventricle, that is ejection fraction, will be within the normal limits. And all this will enhances the clearance of your secretions, that is by means of bronchial hygiene techniques. And most probably the patients are positioned with the area to be drained, the uppermost. But modification that I told you, according to the individual need, you can position. For example, if the patient has undergone pneumonectomy, pneumonectomy means whole lung will be removed. So in that case, you have to position the patient on the same side of the surgery. You can't say that ICD will be in the surgery side and I have to position the patient because the tube has to be on the uppermost. It's not like that. So pneumonectomy means whole lung will be one side of the lung is removed. So to prevent the bronchopulmonary fistula formation, you will ask the patient to lie on the same side of the surgery. Whether he's undergone left side, you ask the patient to go for the left side lying only. That is how it differs. And then drainage time varies, but ideally each position requires 10 minutes. And I already told you position restores ventilation to dependent lung regions more effectively or large tidal volumes. And it has a marked influence on gas exchange because of unevenly damaged lungs. and side lying reduces the lung densities in the uppermost lung. And right side lying may be more beneficial for cardiac output than the left side lying. And simple turning from supine to side lying can clear atelectasis from the dependent region. See, as the gravity, it will pull the underlying the lung. So that is why when you have position, for example, I told in the pneumonectomy, or if it is the patient is having any lobectomy also. In the lobectomy, usually you will position the patient on the opposite side. If he has undergone right lobectomy, you position him on the left side and the uppermost, because you are giving remove only part of the lung, so and the rest of the lung is there, no, so the rest of the lung also should be aerated well. That is why we are positioning the opposite side, and functional residual capacity will decreases from standing to slumped sitting to supine lying. And position affects compliance, that is workout breathing is 40% higher in supine than in sitting. And positioning affects arterial oxygenation by improving ventilatory perfusion mismatch. That is usually in the whoever are teaching the academics, they may know that bad lung should be up and the good lung should be down. Why? Because proprioceptive neuromuscular facilitation principle will work in this scenario, that from the good lung the proprioceptors will send the impulses through the muscle spindles and it will give the aeration to the bad lung, like that they will think, and that is the usually following the procedure in the ICU. And finally, what does the position will say? So the positions, by means of positioning, the lung volume will increases by 57%, and there will be decreased need for positive and expiratory pressure, and the ventilation perfusion ratio mismatch will increases by 12%. And obviously, you know, the shunt in the body is left to right shunt, so that will be decreases by increases by 11%, and there will be decreased barotrauma, increased drainage of secretions, and decreased length of the stay in the ICU. And coming to the next one, which is mobilization, which is very, very important. See, if the patient is critically ill, you will follow the frequent position changes within the bed, or advanced technique like kinetic therapy or kinematic, like rotatory bed, which will be seen in advanced countries. That is, the bed will rotate. We need not to move the patient. So the bed will rotate so that the patient will change his position. And then if the patient is stable, then you go for progressive tilting and then finally ambulating the patient. See, mobilization is defined as the therapeutic and prescriptive application of low intensity exercise in the management of cardiopulmonary dysfunction, usually in acutely ill patients. See, what is the goal for mobilization? To exploit the acute effects of exercise to optimize the oxygen transport. And even a relatively low intensity mobilization can impose considerable metabolic demand on the patient if cardiopulmonary compromise. And ICU rehabilitation has been shown to accelerate the recovery by means of early mobilization for unconscious patient. It starts from turning the patient every 2 hours. See, we did a study in our hospital. By turning the patient every 2 hours, we have seen, it's done very long back. So we have seen his oxygen saturation is increased and his PFT, the pulmonary functions, has improved over a period of time. And then graded exercises can be started as soon as the patient regains a consciousness. And activities required to maintain sensory input, comfort, and joint mobility and healing ability. Why? Because everybody knows when you move, our circulation will increase. Once circulation increases, all the waste products will go off, and then we will have proper oxygen and carbon dioxide availability, and then most of the gas exchange will occur. And then activity minimizes the weakness caused by the loss of up to half of the patient's muscle mass. So these are the simple chest mobilization exercises incorporated with the inspiration and expiration. See, when you stretch your body, like for example, if you lift your hands over the head, then you do inspiration. Why? Because you are stretching all your intercostal spaces so that there may be chance of entering of more air inside the lung. So that is why you will ask the patient, whenever you are doing overhead activities or stretching activities, you incorporate inspiration. Whenever you are coming back to the normal, you ask the patient to go for expiration. So that is how you are going to improve his ventilatory capacity. See, these chest mobilizations, always otherwise called as thoracic expansion exercises or ventilatory movement exercises, strategies, like you are incorporating your movements, that is daily activities. See, if anyone asks you to come and sit and do the breathing exercise, nobody will do. So if you incorporate in their activities, like for example, a woman working at home, if she is doing any kitchen activity or taking any item from the shelf, if you ask to incorporate these exercises, they might benefit. See, that is why I said that individual protocol is very, very important for a particular condition. And coming to the breathing exercises, see, generally we'll ask the patient go for diaphragmatic breathing if he is not using his main inspiratory muscle. So why? Because the main inspiratory muscle is diaphragmatic diaphragm. See, once the diaphragm moves up and down during the inspiration expiration, then only the abdominal pressure increases and all the carbon dioxide will come out. That is why we'll emphasize on the normal diaphragmatic breathing exercises, which concentrates on the epigastric and lowerly movements and concentrates on allowing the whole abdomen to swell as diaphragm descends. See, everybody, they said, yeah, I'm doing breathing only, normally I'm doing breathing. See, if you are doing observing, when you climb the stairs, for example, the exam time is over, so you are running to go for the exam hall, so you will get panic. At that time, if you observe, you will urge for breath. Automatically you will lean your back or stretch your legs while sitting, so that you can reduces your urge for breath. And then you will concentrate on your abdominal breathing. See, it's not like abdominal breathing, you are using more of the diaphragm. See, whenever you are inspirating, the diaphragm should come out, that is, the belly should raise. Then while expiration, the diaphragm should go, like belly should go inwards. That is the normal pattern of breathing. So for the males it is abdominal thoracic, for the females it is thoraco abdominal. So you have to maintain this normal pattern of breathing for the males and females, and then and then teach the proper breathing exercises. This is how you are going to teach. And then once you taught, then you ask the patient by himself to do by placing his both hands over the abdominal. And once he has mastered the technique, he understood the technique, then you ask the individual or patient to go for breathing exercise in different positions, like first supine position, then semi forward position, then sitting, then while walking, and then while, for example, if he is walking through, within the ICU, you ask the patient to incorporate the diaphragmatic breathing exercises. And coming to the segmental breathing exercises, segmental breathing exercise is nothing but whenever a particular lobe is get infected or particular lobe get accumulation of secretions, then you are going to emphasize on the segmental breathing. So particular segment, you are going to give the stretch during the inspiration and then ask the patient to go for expiration. See, like this you have to do by yourself. If you are not available, you if the patient is having strength, you ask the patient to go the segmental breathing by himself by holding a towel. This is the posterior basal exercises. And if the patient is doing by himself, he has to place his hands on that particular lobe and then give an inward stretch while doing inspiration. And remember one thing, all the breathing exercise should end in like doing the pursely breathing, whatever may be the type of breathing, whether it is coastal breathing, segmental breathing, diaphragmatic breathing, or apical, any type of breathing, except glossopharyngeal, all the breathing patterns will end in pursely breathing. That is, you have to inspire. I already told you, normal inspiration expiration ratio is 1:2. That is why whenever you are going to take 1 second of inspiration, the expiration should be 2 seconds. And that too with the pulse sleep, like by blowing your candle or blowing your balloon or air. So you should keep your mouth like O shape, and then you have to blow the air slowly, so that the patient may get relaxation. And also your respiratory rate will reduce by doing the pulse sleep breathing. That is the main advantage. All the breathing exercises should end up in pulse sleep breathing. And coming to the airway clearance techniques, there are a lot of airway clearance techniques, like mechanical and manual or physiotherapy assisted, or the patient himself, like self-assisted techniques. So most probably we'll allow in the ICU postural drainage positions, and then chest physiotherapy, which includes percussion, vibration, and shaking. And if the patient has a copious amount of secretions, you will go for manual hyperinflation. And if the patient is having like mastered the technique of how to do to drain his own secretions, then you go for manual techniques like self-assisted techniques like active cycle of breathing technique or autogenic drainage or positive expiratory pressure with the help of like a small instruments like a flutter, acapella, quack. And then in advanced countries, they are using high frequency chest compression or exercises for the airway clearance. These are the you must be following, I mean, the BPT, or who is done, I mean, like MPT or clinicians also, they must be frequently doing in the ICU postings. This is the vibration and then shaking. And then coming to the percussion, see, most of them till now, even my students are not able to do the percussion also, because they don't know how the procedure and what is the effect of doing the chest wheeze. See, you are just mobilizing the secretions from the periphery to the center. See, you are not removing with the chest physiotherapy or postural drainage. You are moving the accumulated secretions from the periphery to the central, so that by means of his coughing maneuver, you are removing. If the patient doesn't have cough, then you are opting for the suctioning. That is why all these procedures, this posture dynamic depends upon the position of the lobe. So you are positioning the patient so that the secretions can move from peripheral to the central airways. And this is manual hyperinflation. See, when the patient is having copious of secretions, if he is not able to, like, by means of vibration, shaking, percussions, the secretions are not moved, then you go for manual hyperinflation. That is, manually you are hyperinflating the lung by means of ambu bag. Ambu bag is nothing but artificial manual breathing unit. See, by means of this ambu bag, like it may be 1 liter or 2 liter bag, you are creating, you are infusing more amount of air inside the lung, so that the secretions may push out from the periphery to the central. So once it reaches the central, you ask the patient to cough, or if the patient having weak cough or nothing, you do the tracheal tickle, or if the patient doesn't have the cough, you go for suctioning. And these are the positive expiratory pressure instruments I told you, acapella, flutter. So these instruments, by means of the like individual or patient itself, they will create the positive pressure inside the instrument, which will create the oscillatory pressure to the lung, so that the alveoli will have more of air and it will pushes the lung, secretions, sorry, it will pushes the secretions from the periphery to the center. And coming to the self-assisted techniques. Self-assisted means the patient, we teach the patient so that he can do by himself. Like in among that, active cycle of breathing techniques, the one mainly using. So in this, we will ask the patient to go for breath control. Then once he is mastered in the breath control, and then ask for the thoracic expansion exercises. Once the thoracic expansion exercise is done, then you go for forced expiratory techniques. So initially the forced expiratory techniques consists of huffing, then go for cuffing. See, huffing is very, like coughing is more energy consuming the process. Like if you cough more, then you will get cough syncope also. That is why we'll start initially with the huffing, then go for cuffing. Then another one self-assisted technique is autogenic drainage. See, this autogenic drainage depends upon the lung volumes. You are going to have three phases. One is unsticky phase, collecting phase, and evacuating phase. That is low volume, tidal volume, mid lung volume, and then tidal one. See, all these depends upon the how much of volume you are going to inspire. That is, the therapist will teach the patient to inspire in the tidal volume level only. So middle lung volume only, then higher lung volume only. See, like this, so that the adhered secretions will unstick from that, then collect in the peripheral airways, and then it go for central airways. By the way, you can evacuate from the patient's lung. And if all these techniques are not at all useful, then you go for the facilitating the accessory muscles. Like for example, in neurological conditions, there will be phrenic nerve palsy, like that GBS syndrome, excuse me, then motor neuron disease, all these, like pseudobulbar palsy. The patient may not able to cough, or patient may not able to have a normal breathing pattern. So in order to have retain the near normal, you are going for the stimulation of the accessory muscles, even though it is not good, but you have to make the patient somehow better, to prevent him from the abnormal. So you are going to facilitate pectoralis major or sternocleidomastoid, or trapezius or serratus anterior. See, this facilitating is nothing but you are going to like means of giving input pressure into the particular muscle so that it will act and it will help indirectly in the process of inspiration. And normally these are all the activities we usually give to the patient once he's like fit for moving within the ICU, like he's going to have from the ICU to the general ward. Then you depend upon his met levels, that is metabolic equivalence, that is how much of oxygen he is going to spend for each activity. So this depends upon this met values only you are going to emphasize your treatment protocol. Like for example, for resting, eating, writing, all this you need one met only. See, for light housework, you need two meds only. See, like that washing and dressing. See, initially you will ask the patient to go for 2 to 3 meds only in the ICU. And once he is more better in ICU, then you ask the patient to go for 4 to 6 meds. Like that, you have to prioritize and hierarchy the goals. Then only the patient will get the improvement. And finally, nowadays the advanced technique, like in the pulmonary rehabilitation, you are going to have the proprioceptive neuromuscular facilitation, as you are having the patterns in the lower limbs and upper limbs, which will incorporate in the normal daily activities. Our main goal is to preserve their energy, that is energy conservation technique should be incorporated with the help of inspiration and expiration, that is normal respiration. So the neurophysiological facilitation is promoting or hastening the response of neuromuscular mechanism through proprioceptors. And these are cutaneous proprioceptive stimulation reflexively increases the depth of the breathing. So most probably these techniques will be used for the drowsy patients that's unconsciously and post-operative surgically, and those with neurological conditions, and partially breathing patient on ventilator, especially if they are unable to turn. See, those patients will have this PNF techniques. And what are the PNF techniques? Mostly you will use is stimulation of diaphragm, and then perioral technique, intercostal stretch, and co-contraction of abdominal muscles and vertebral pressure. See, we did a study in our college that intercostal stretch in COPD patients, and we emphasized on the pulmonary functions of the COPD patients, that to mild to moderate COPD patients, and they showed better improvement in the pulmonary function, especially their vital capacity is increased by applying this intercostal stretch in the ICU. So stimulation of diaphragm is, see, all these techniques is nothing but you are giving input and you are stimulating the muscle spindle. Like what principles of PNF are there, no, like reversal principle, input should be transferred from one muscle to the another muscle. So like that, these PNF techniques will act, and then they will increase the depth of the breathing. Finally, they'll have normal respiration and improved in their condition. See, now I
Good
ended
evening.
the session. Now it's open for questions. Anybody is having, then you can ask me.
Good evening, ma'am. Iram here. Ma'am, I'll be forwarding you the questions. The first
Okay.
question is from Dr. Rajesh. Can you explain the post-COVID 19 chest care?
Okay. Okay. See, in the post-COVID-19 chest care, first of all, you see what are all the condition of the patient. See, every COVID patient doesn't have the respiratory system is abnormal. They are asymptomatic also. See, in the chest care, what we are going to see, especially in this pandemic, means, see, first you see what is his respiratory rate, what is his BP, and what is his saturation of oxygen. Why? Because nowadays most of the patients ignoring the oxygen saturation and they are thinking we are fine. So that is nothing but silent hypoxia or happy hypoxia. So they don't know the oxygen saturation levels are suddenly falling down and they are going for the faintness. And even if they are not recognized, and they may go for like the deaths are also happening. So that is why you are very very important to see the saturation of oxygen in the COVID patients. And then usually you have to go for HRCT, that is high resolution CT. You have to see, because in asymptomatic patients the virus is not showing in the chest X-ray. You have to go for high resolution CT. resolution test CT, then you can see the choroid score. Then depending upon that, you can classify whether it is going for pneumonia or your lobes are very clean. Like that, you have to take care the COVID patients.
I hope Dr. Rajesh got the answer. Ma'am, the
Am I
next.
clear? Am I clear?
Yes, ma'am.
Tell me, ma.
Ma'am, the next question is, can you explain diaphragmatic breathing?
Okay. See, diaphragmatic breathing is nothing but you ask the patient to sit in his comfortable position. It's nothing like that. In the book, it has given semi-follows. You make the patient sit in the semi-follows position only. See, according to the individual need, if he's comfortable in lying, you make the patient in lying. Or if he's comfortable in sitting, you make the patient in sitting. And you ask the patient to hold, clasp both the hands and keep over his tummy, like exactly over the Ziffy's tunnel process, and ask the patient to take deep inspiration. And then during inspiration, he has to feel that raise of the abdomen, that is abdomen is coming out, so that he can feel by raising his, by feeling the with the palm of the hands, that is abdomen is coming out. And then during expiration, the abdomen has to go in by doing the pursely breathing, like whistle, like you are going to blow the balloon or blow the candle, you have to blow the air like nothing but the pursely breathing. So that is the diaphragmatic breathing. Am I clear, ma?
Yes, ma'am. The third question is from Dr. Ashwini. Can you explain energy conservation technique?
Okay. See, energy conservation techniques is nothing but you are going to conserve his energy. Once he was, I mean, like in the ICU, you can't ask the patient to walk for 15, I mean, like 6 meters or 10 meters or 30 minutes or, I mean, continuously. So you are to going to conserve his energy. For example, if it is emergency only, he has to go to, I mean, like if he wants to eat something, it should not be far away, so it should be within the reach of the patient so that he can take and he can conserve his energy. And for example, he want to wear his shirt, so that shirt need not to be having buttons because it is time consuming and energy consuming. So in order to that, you have to have the zip like that, all velcro strap like that. So you, in that way, you are going to decreases the energy of the patient so that he may have like proper breathing, because already his respiratory system is in compromising state. So to reduces this work of breathing, you are going to have the energy conservation techniques. Even in the home also, you have to follow the same thing. Once he discharges, you have to keep everything in reach of the patient so that he cannot use much of his energy, so that he cannot compromise in his respiration. Am I clear?
I hope Dr.
Ashwini.
Ashwini got the answer.
Yeah.
Ma'am, the fourth question is from Dr. Khalik. If the patient is receiving O2 therapy through mask, then can we advise him to do breathing exercise?
Yeah, if the oxygen is through the mask, means how long, mean like continuously they are keeping, or through the nasal cannula, or it is high, like through the ventilator. You have to see when the ventilator is on and off. See, when while you are weaning from the ventilator, you are going to remove the mask and ask the patient to do the breathing exercises. If there is no plan of weaning of ventilator, you can't ask the patient to remove the mask and do the breathing exercises. So you have to see how the condition of the patient, how much of oxygen they're supplying.
I hope Dr. Khalik received his answer. Ma'am, there's one more. Can you explain respiratory PNF?
Okay, okay. See, respiratory PNF is nothing but actually these are the proprioceptive neuromuscular facilitation. You are facilitating the muscle spindle, like Golgi tendons and muscle spindle within the respiratory muscles, so that the inputs, the peripheral impulses are going to the particular muscle and they are facilitating. For example, I am not getting that word, that's why I'm sorry. I didn't remember exactly the word, like it starts with R. So that principle, if you give, then automatically, like that is why we are positioning the patient in the opposite, that better lung should be up, bad lung should be up, and better lung should be down. So if the better lung should be down, so this proprioceptive neuromuscular facilitation occurs, and these will send the efferent impulses to the uppermost lung, so that uppermost lung also will get benefited and the disease will get reduced. Like that, that is why we are using the proprioceptive neuromuscular patient mostly in the ICU, because they are not able to have most of their mobility. So we are using this. And how we are going to facilitate the diaphragm means, see, you have to place your palm of the hand over the dome of the diaphragm, whether it is left side or right side, any dome of the diaphragm, and you are going to give inward stretch. See, is nothing like but stretch reflex. So you are stretching the particular muscle so that the impulses may get carry over to the other part. That is how we are increasing the depth of the respiration. Am I clear, ma?
Doctor, ma'am, one more question is, if the patient is in coma or unconscious, then what is the respiratory protocol for the patient?
See, once the patient is coma, you have to see how, what is the Glasgow GCS scale, whether he is responding or not, whether he is verbally good or whether he is responding to the pain. Then according to that, you have to decide your protocol. If his patient is unconsciousness, you have to concentrate mostly on the positioning. That is why I said the positioning itself will give the 50% improvement in the patient. So first, you have to properly position and do the limb exercises like ankle toe movements, pump movements, as the caretaker to do that activities one unconscious. So only the positioning makes the individual go for the better improvement in his condition. And then do proper chest physiotherapy. If there is any secretions accumulated, go for proper chest physiotherapy so that you can drain the secretions by means of suctioning. Then you can have well ventilated lung. Am I clear, ma?
Yes, ma'am. Ma'am, there's one more question from Dr. Dikshita. Can you explain VQ mismatch?
Okay. See, ventilatory perfusion ratio is for why it is very important means our lung is gravity dependent. Okay. See, gravity dependent means the lung will be pulling down. That is why upper lobe are well aerated and lower lobe are well perfused. So that is why you are having mostly the infection of the lung occurs in the lower lobe and middle lobe only. Never upper lobe will get infected. If you see any case, even in TB or bronchiectasis, most probably the middle lobe and lower lobe will get infected. Why? Because perfusion is more in the lower zones and well aerated, that is ventilated, is more on the upper zones. Why? Because that is why the lower and middle lung get infected. Why? Because the blood is the good medium for the growth of the bacteria. So to keep in this mind that ventilation perfusion, that ventilation is more in the upper zone and perfusion is more in the middle and lower zone. So you have to position the patient according to the ventilation perfusion ratio. See, most probably the prone position is the best position. Why? Because the ventilation perfusion, there is no mismatch. How much of ventilation is going to have for the lung, that much of perfusion is going to have. That is why most of the patients in the now even in the COVID cases, most of them are opting by himself the prone positions. Even in our hospital, our one of the doctors got infected, like a neurologist got infected, and he himself thought that prone position may increase my respiratory symptoms. So he usually for daily started using the prone position for 2 hours and later increased for 3 hours, like that, the duration. Then he got better improvement and he discharged like within a week after getting the COVID also. So the ventilation perfusion is the ratio which will have more impact on the respiratory function. That is why ventilation should be proper and perfusion should be proper. That is why the position should be opted for prone. After, if the patient is not comfortable, and also if he is in ICU, all the lines will be there. So the side lying is the better position to have ventilatory perfusion ratio within the normal. Am I clear, ma?
I hope Dr. Dikshita got her answer. I would like Dr. Rajeshri to come ahead and ask her question to ma'am. Dr. Rajeshri.
Good evening, ma'am.
Good evening, ma. Tell me.
Ma'am, a patient has been suffering from COVID for past 45 days, ma'am. He has been admitted He was having PF less than 60, ma'am. But he was in ventilation only. Little bit it was increasing. Before 20 days, it was about 350, ma'am. PF ratio was. Now
Okay.
again it came down to 60 or 70 something, ma'am. Other than COVID, now he was getting pseudomonas infection also in his lungs, ma'am. So could you
So
tell
maybe
me what kind of?
he may got ventilator associated pneumonia, ma. Maybe he
Yeah, ma'am.
got affected with ventilator associated pneumonia. So he might have to be more of emphasizing on removing the secretions and having more of chest mobilization, because pneumonia is a restrict to lung disorder. See, I
Yeah, ma'am.
forgot to say in this session, sorry. Actually, the obstructive lung disorders and restrictive lung disorders, there is a lot of difference in the treatment protocol. So many people are thinking that whatever may be the treatment, the patient is having any respiratory disease, they are going to give the breathing exercises. It's not like that. For restrictive lung disorders, you have to emphasize on the mobilization exercises, because he is not having any dyspnea. Pneumonia patient doesn't have any dyspnea, he will have tachypnea. The rate will be more. So in order
Yeah,
to
ma'am.
reduce it, you have to ask the patient to, mean, like the patient is unconscious, no, now.
He was in sedation, ma'am.
Okay, then you have to see to that proper humidification should be provided, and the proper amount
Okay.
of oxygen should be given through the ventilator, that it should not be like more oxygen toxicity. And you have to do the limb movements passively, so that he
Passively.
may, yeah, he, because
Mm.
he's in sedation, no, he's not able to do, no.
Yes, ma'am.
You ask the caretaker to do the respiratory, mean, limb movements, and then proper positioning, frequently turning every 2 hours, then you might
Yeah.
get any improvement.
Okay, ma'am. Okay, ma'am. Actually, to remove the secretions, they have done tracheostomy by doing suctioning. They were removing secretions, ma'am. PF is
Yeah, but
coming 370, but after they are trying to reduce the ventilator settings, he was starting to cough very badly, and PF is coming very down, ma'am. That's what the major
oh,
problem. 6 to 7 attempts they have been done. While increasing the PF ratio, it was coming 370 like that. Normally, when they try to reduce the ventilator setting on that time, he was starting to cough. That too, productive cough it was coming, ma'am.
okay, maybe he's having like I told you, no, ventilator associated pneumonia. So but frequently if you do also, then he will get more of mucus damage, and then already ciliary action will get reduced. So you have to see proper humidification only is the main thing, I think so.
Okay, ma'am. Any because of drugs, it will be like that, ma'am, or else
Yeah,
what kind of?
usually, ma, they'll give the mean, like drugs, that's what I'm saying. Whether he's having any other comorbidities, whether it's diabetic or
Ma'am, he
hypertensive.
doesn't have anything, ma'am. He doesn't have BP, diabetic. Only 34 years old, man.
Oh, okay, okay. But
No, there is no smoking, no
once
alcohol,
you see
nothing.
the condition, like he has undergone HRCT, ma,
No, ma'am.
you ask the hospital people to go for HRCT. Maybe he's having any lung infection. Why? Because
Okay, ma'am.
my student also having continuous of secretions and this thing, even though she doesn't have any problem, they diagnosed it as a TB in the upper
TB.
lobe. Yeah, TB in the upper lobe.
Oh,
They diagnosed it after 1 month. So
okay,
maybe
ma'am.
he's affected that, like that. You can ask the patient to go for, I mean, like, doctor to request HRCT. You might be knowing what is the underlying cause.
Okay, ma'am. But they have taken 15 days back. They have taken CT, ma'am.
Okay.
And on that, they have ruled out that there was slightly pulmonary fibrosis. There was scarring in the lung tissue, it seems, ma'am. Because of
Oh,
COVID,
okay.
secondarily it will be coming. But once the infection comes down, it will be resolved on its own, like that they told me.
Now he is negative for COVID.
It has been 45 days, ma'am. Those doctors were telling that it will be negative like that, ma'am. Only
But you have
Pseudomonas
to do,
infection has been growing on, growing, ma'am. They have given
but
giving
see,
antibiotics, but that single
particular antibiotic,
organism.
particular antibiotic should be given, mas. Fourth generation of cephalosporin should be administered to that case, so that he may resolve for the pseudomonas.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
Thank you, ma. Welcome.
Ma'am, what is the reason behind silent hypoxia? The question. This is the question from Dr. Ria.
Okay. See, silent hypoxia and happy hypoxia is nothing but fall in the oxygen saturation. What is the reason means? Normally, if the patient is get infected with COVID, so what will happen? The respiratory system will gradually reduces his oxygen and carbon dioxide diffusion. The diffusion of the oxygen and carbon dioxide will get reduced in the higher centers. So what will happen automatically in the blood capillary membrane? The exchange of oxygen and carbon dioxide will reduces. So that reducing will give a chance to accumulation of these H plus ions and carbonate ions. See, bicarbonate ions and these H plus ions will get accumulated, which leads to like acidosis and alkalosis. So the which might the patient doesn't know because his immunity level is good and he is asymptomatic. Once this happens, what will happen? This carbon dioxide is the drive for the respiratory system. It's not like the oxygen. See, once the carbon dioxide gets accumulated in our body, so it may form carboxy hemoglobin, so which is most poisonous. So there is no chance availability of oxygen to have the exchange with the carbon dioxide, so it get more poisonous. So the patient doesn't know, suddenly the oxygen saturation will fall and he may go for hypoxia. Am I clear, ma? Hope
Dr.
I
Ria.
cleared the doubts.
Yes, ma'am. Ma'am, there's a question from Dr. Abdul. What is the time duration between two sessions according to the international guideline?
Which two sessions, ma? Actually, I mean, what two sessions?
Sessions between like ICU patients, like sessions for the cardio.
As a minimum half an hour should be there, ma, within two sessions. Like you can't give immediately. For example, if the patient is having morning breakfast at 8 o'clock, you should start your treatment by 9:30, and then yeah, continue your treatment by 10:30, 11. After that, you go again at 3 o'clock or 2 o'clock once he finished his lunch. Like that, you have to be a gap of minimum half an hour.
Okay, ma'am. And ma'am, Dr. Ketki, can you come ahead and ask your questions? Dr. Ketki.
Ma'am, I'm a student. Uh, uh, Ma'am, for mechanically ventilated patients, what are we supposed to do?
See, for mechanically ventilated patients, first you have to see whether patient is having his own breath or not. That's respiratory drive is there or not. So after seeing that, what is the mode of the ventilation? See why? Because there are different types of ventilator: pressure ventilators, pressure positive ventilators, negative ventilators, and pneumatic like gas filled ventilators. The power should be whether it is pressure or time or volume, whatever may be. So first, whenever the patient is on mechanical ventilator, what is the mode given for those particular patient? Whether it is controlled mode, if everything is taken over by the ventilator, then you have to give proper humidification positioning, because you can't ask the patient to go for breathing exercises at that time because he is already connected to the ventilator. If the patient is having his own breath control, then you may teach breathing exercises. Then automatically after breathe positioning, you go for breathing exercises, go for position in the sitting, then you go for out of the bed, then walk within in and around the ICU. Then no, like after that, once his oxygen and everything is near normal, he may automatically discharge it. Most probably the ICU patients will be there within for 7 to 10 days only. After that, they may get discharged. Usually I have seen 5 to 7 or 7 to 10 days. And if there are any secretions, you have to do chest physiotherapy. And if he's starting to cough or he's having weak cough, you have to enhance his cough. And if you're not having any cough reflex, then you go for suctioning to remove the secretions. There is a management for the mechanical ventilation. If the ICU doctors are so busy, so supportive and so giving opportunity, then you make the patient go for prone position and see the effect. And in the supine lying, you are taking like 5 to 7 days for the improvement. In the prone lying, you will get within 3 days the improvement. Am I clear, ma?
Ma'am, and when are we supposed to start PT for a ICU patient? Till what is the ideal time?
See, it's nothing like ideal time. That's what I'm saying. It depends upon the patient. See, immediately you can't do your chest physiotherapy after the breakfast. So after 1.5 hours of his breakfast, that is why in ICU, the nurses will give early breakfast for them. It's not like the 10 o'clock, 11 o'clock. Usually the doctors will go rounds at 7, 8 o'clock and 9 o'clock usually. So before that only, the nurses will ask the patient to finish off his breakfast. So once the doctor rounds, then you will do the physiotherapy. Whatever he is in need, whether he is in chest physiotherapy or he is in need of mobilization or he is in need of any other breathing exercises, everything.
Ma'am, I meant as in what should be the patient's condition? Like if it's very critical patient, can we
If
means what should that time in that terms, not
critical patient
during
timing
the day
means
of.
like you have to see his vital signs first, whether he is stable or not. If he is stable, then you can go for your normal protocol. If the vital signs are haphazardly jeopardizing, like within, changing frequently, you can't give your treatment. You have to wait until his vital signs stable, then you go for your protocol. Usually morning times is better because everybody as a student, you think morning class is fresh for you or afternoon class is fresh for you. Obviously the morning class only is fresh for afternoon. Everybody will go for sleep, and evening we will all the students will keep the faces like as though you have done lot of works and you have to leave the college like that. So most probably morning only will prefer, ma.
Thank you
Are
so
you
much,
clear,
ma'am.
ma?
Yes,
Okay,
ma'am. Thank you, ma'am.
okay, ma, welcome.
I would now like to hand over it to Dr. Renuka to speak a few words, and the rest of the questions will be answered to you. Don't worry.
Good evening, everyone. Good evening, Dr. Varalakshmi, ma'am. It was a wonderful session. Uh,
Good
myself,
evening, ma.
Dr. Renuka, myself, Dr. Renuka Deshpande, Vice President at Cornerstone All India Student Organization. I would like to take a minute to mention about our organization to you, ma'am. The organization by the name Cornerstone All India Student Organization, as it goes now, was established by our founder, Dr. Suchita Golar, ma'am, assisted by our national advisor, Dr. Rajesh Sange sir, and our international advisor, Dr. Mahindra Yadav sir, in the month of June, with our first event by ma'am herself, along with the speaker from South Africa, Dr. Barry Gates sir, on how to boost immunity and cope up with this pandemic situation. Since then, along with Dr. Golar ma'am, with our advisors and team's efforts, we have executed 12 individual and series of such webinars on different topics requested by the students. As she believes and always tells us that this organization is for the students and by the students, we are very proud to be a part of this organization, and we thank you all for joining here and sharing the valuable knowledge with us. We look forward for such events and events with you as our speaker and as our constant guidance. Thank you so much, ma'am.
Thank you so much for your lovely words. See, first of all, I would like to thank my principal, Mrs. Hannah Rajshekar, for approving my the webinar to have, to go through this. And nextly, I should thank the Sucheta Golhar man, who is the founder of your this Cornerstone. And then after that, I should thank Rajesh Sange sir and Mahendra Yadav sir and Shweta, who is continuously in touch with me about asking what is the topic and any other queries, anything. And then the Renuka also, who work hard to have this session go smoothly. I thank each and every participant who made this webinar to go very smoothly by muting their mics, and hope I cleared all the doubts for all the students, and hope in near future I may have more webinars from through this platform also. Thank you so much for everyone. Thank you one and all.
Thank you, ma'am.
Thank you, madam. I am Sucheta. So it was a very excellent webinar, and I am very damn sure that the students have gained the knowledge, and you have showered your with large efforts you have showered your knowledge to them, and they have gained much more knowledge. And of course we will try to keep much more webinars in future as per your convenience. And also thank you to the Cornerstone team and the participants also for joining us. And God bless you all. Take care, stay safe.
Thank you so much, ma'am. Thank you for this opportunity given for me. Thank you.
Thank you.
Um, uh, Ma'am,
Yes, yes, please.
should I proceed with vote of thanks?
Yes, yes, please, yes.
Good evening, all. As all the beautiful things come to an end, so is this beautiful session. Today, I, Dr. Iram Kazi, on behalf of Cornerstone Organization, extend my hearty vote of thanks to our resource person, Dr. Varalakshami, ma'am, for gracing today's webinar. A big thank you, ma'am, for enlightening us with your knowledge, as this was much required because none of us had no knowledge about how to manage patients in ICU. I would also like to express a profound gratitude to Dr. Sucheta Golar, ma'am, Dr. Rajesh Sange, sir, and Dr. Mahendra Yadav, sir, for their constant motivation, moral support, and guidance. A special thanks to our organizing team members for putting their efforts and coordination to make the session successful one. And a heartfelt thanks to delegates for their active participation. With this warm words and kind message, we move to end our today's webinar. Thank you.
Thank you so much for everyone. Thank you.
Thank you, ma'am.